Our next speaker is Dr. Bradley Thrasher, going to talk on sports, exercise, and type 1 diabetes. Dr. Thrasher is a pediatric endocrinologist and associate professor of pediatrics in the Division of Endocrinology. He serves as the director of the Christensen Family Sports and Activity Program for the Wendy Novak Diabetes Institute. Additionally, he serves as the pediatric director of the Wendy Novak Diabetes Institute itself. He completed his medical degree at the Edward Via College of Osteopathic Medicine, his residency at Wake Forest University School of Medicine, and his fellowship at the University of North Carolina at Chapel Hill. Welcome, Dr. Thrasher.
All right, well, good morning. I'm Brad. It's nice to see you all out. I think we're ahead of schedule. Would y'all like to stand up and just stretch for like 1 minute? Would that be cool with everybody or no? You want a minute? Like my wife told me to stand up before I got up here, so I'll give you a minute to stretch. All right, a minute's more like 30 seconds. Okay. All right, so we'll go ahead and get started. So, but as I said, I'm one of the pediatric endocrinologists here in this area, and it's an honor to be with you all. And I'm going to speak on a topic that's pretty dear to me, and it's just kind of exercise in those with type 1. Have no conflicts. 3 little learning objectives here. We're going to just talk about how different types of exercise impact blood sugars. We're going to go over different insulin strategies that we use to try to help prevent hypoglycemia. And then I'm just going to show you all technology that we use. So before we get in kind of to the meat, I always like to talk a little bit about history. So insulin was discovered in 1921. And I have here a little map from 1921 to current. And this is just me putting in PubMed, diabetes and exercise. So you can see for many years, there's really no research in this area. And the last few decades, we've seen a kind of an exponential rise, but there's still a lot of research that is needed in this area. It wasn't too long ago, this is a quote from a paper in 1979, that we really didn't even recognize those or recommend those living with type 1 to participate in sport and activity because the erratics in the blood sugars were just too extreme. So this paper I thought was interesting because the title says, basically I only recommend exercise to those who are pretty much well controlled. The world has since changed, and now the American Diabetes Association recommends everyone living with type 1 participate in activities. And if you just kind of look at history too, there's a lot of professional athletes now living with type 1, from baseball to football, soccer to tennis. Last year, I took care of 3 kids that went on to go play sports at the college level. That's pretty cool. It's real cool, actually. Type 1 diabetes is increasing in incidence, about roughly 2 to 5% more a year now. Why it's happening, we don't know. About 64,000 people each year in America are diagnosed with type 1. Right now, last statistics about, in total, still less than about 1% population, but 1.8 million people live with type 1 every day. So, we come across these people in everyday walks of life. We know there are benefits of exercise. It helps improve our cholesterol levels. We sleep better at night. We tend to have a better mood if we're participating in daily physical activity. But one of the main barriers of why people living with type 1 don't participate is the blood sugar changes that come with the biggest one being hypoglycemia. When I was in training, I had a family who pulled their kid out of baseball, and they just said his blood sugars are too hard to manage when he plays a sport. When he's at home, when he's at school, numbers are not that bad. He starts playing sports, and we're tired of dealing with it, which is really sad because sports teach us so much life lessons as well. But hypoglycemia is the big reason why a lot of people choose not to participate in activity. So this is the boring part of my slide. So we're going to do a little bit of physiology here. So when we talk about kind of glucose transport, there's 2 main transporters, GLUT1 and GLUT4, that pull glucose into skeletal cardiac muscle. GLUT1 is non-insulin mediated, kind of just passive diffusion. GLUT4 is insulin mediated. So when we eat our meals, our blood sugars rise, our pancreas starts releasing insulin. Insulin binds to its receptors, and we have an uptick of GLUT4 on our cells to help lower our blood sugars. Well, GLUT4 is also mediated by muscle contractions. So when an individual living with type 1 goes to participate in an activity or sport, one of the reasons they're at risk for lower blood sugars is because the muscle contractions themselves are going to upregulate these GLUT4 transporters to help lower blood sugars. And if they have mismatched how much insulin they have on board with the activity that they're going to be doing, they're also going to be having upregulation from insulin, which those of us living without type 1, we're really suppressing our insulin during exercise. So during times of activity, it's just that muscle contraction that's impacting GLUT4. This slide here just kind of shows a normal individual, meaning like you don't have type 1 diabetes, what our blood sugars do. So when we start to exercise, and this was looking at moderate activity. So, you're running, you can talk to somebody, but you're not able to sing to somebody. Our cells start uptaking glucose. We need it for fuel, but we don't go low because our liver typically responds through gluconeogenesis and glycolysis to give us the demand of that fuel that we need back, which is kind of the middle picture there of the gluconeogenesis and the glycolysis. The lower picture is showing that if we didn't have that, we would go low. Most people around 2 hours, if you do moderate activity, you don't fuel yourself at all, are going to start having lower blood sugars. I like this paper too, because they hit on another, I think, valid point of individuals living with type 1 diabetes who are on insulin. Also probably, or they do have some impairment of that hepatic rise of glucose when they exercise, because insulin's a strong hormone. It's a counter-regulatory hormone to glucagon, cortisol, epinephrine, the hormones that kind of help with gluconeogenesis to sustain normal blood sugars during times of activity. So if an individual living with type 1, again, has too much insulin on board when they start to exercise, their body's not going to be able to adapt appropriately and give back the sugar that they would naturally be making endogenously. And there's many challenges with living with type 1 and exercise. I think as endocrinologists, we try to simplify it a little bit too much of what's your blood sugar, what are you going to eat, go forth. Altitude has an impact. Temperature has an impact. A female on their cycle, that's going to impact. How much did you exercise yesterday? What was the duration of your exercise? What was your nutrition like, yesterday or this morning? Many factors, many variables go into the management of type 1. Looking at studies, so just kind of the exercise impact on blood glucose levels. This was a study done in the early 2000s, and they brought people in and they said, okay, let's just start looking at if we do a resistance exercise, if we do an aerobic exercise, if we don't have you exercise at all. So the top line is you come in and you just sit around for 45 minutes and you do nothing. You can see the blood sugars really don't change a whole lot. The line that drops really fast is these individuals were brought in and they did 45 minutes of aerobic activity. So they got on a treadmill, they ran up for 45 minutes. They showed that, man, you have a really rapid decrease in your blood sugars. And these individuals, a lot of them had to end up getting treatments, meaning they had to eat carbohydrates to prevent more profound lows and to sustain. And the middle line is individuals who came in and did resistance training. So they lifted weights. They had three sets that they did for 45 minutes. And you can see, yeah, the blood sugars went down, but it was a more gradual decline. And then they had more stability following the activity. This paper was postulated, well, we don't really know why we're seeing this resistance. Maybe it's the lactate that we build up in resistance exercise that's going into gluconeogenesis. But then, as all good papers write, they said more areas of study are needed in this area. That same group said, okay, well, showed that aerobic declined rapidly, resistance kind of held steady. Could we offer like a recommended approach of how should someone living with type 1 diabetes exercise? Like, if they do aerobic exercise first, should they follow it with resistance exercise to kind of help stability? Or should they do resistance first, followed with aerobic? So the top line, so they brought these same candidates in pretty much, and they did 45 minutes of aerobic, followed by 45 minutes of resistance, or 45 minutes aerobic, or 45 minutes of resistance, followed by 45 minutes of aerobic. So the top line is the people who did the resistance training first, followed by aerobic activity. The bottom line was aerobic first, followed by resistance. And they follow these individuals not only for a few hours after the activity, but the bottom graph is showing that they also follow them overnight, because one of the biggest fears is hypoglycemia after activity, especially when you're asleep at night. So they wanted to see, how did these people do? And they really showed no statistical significance in those who were, no matter what type of activity you did first overnight, But they did say that those who did aerobic activity first, when they did have lows, it tended to be a little bit more profound than those who did resistance first. And then this paper here just looked at resistance training only to see, is there a sweet spot for how much resistance training someone should do? So they either had them do 1 set that was 14 minutes, 2 set that was 28 minutes, or 3 sets that was 42 minutes, or they just rested. And it was kind of interesting because if they did 1 or 2 sets, they had more of a rise in their blood sugar than if they did 3 sets. And if they rested, really no change. Why they found this, they really couldn't postulate as to why. They kind of went down the road of counter-regulatory hormones, but weren't able to prove it. So I like this slide. It's from 2017 from a group, Mike Rodell's group out of Canada. And I think it sums up nicely that those who do aerobic exercise, blood sugars are probably going to go low. They will go low, depending on the duration and intensity of the exercise. If we do anaerobic activities, we tend to see rises in those blood sugars. And in my world, most kids are doing type of mixed of activity. So we can both have spikes and declines. And they talk about the variables here. You know, again, it's not just what's your blood sugar, what did you eat? It's, well, what is your blood sugar, what did you eat, but what did you do yesterday? What did you sleep the night before? What is your just level of conditioning that you're at currently? So it makes it challenging. But even though these challenges are there, we know that the benefits of exercise are well worth the risk. So now the American Diabetes Association for the last decade has really been recommending children living with type 1 participate in at least 60 minutes a day of good physical activity, and adults participate in 150 minutes a week spread out over minimally of 3 days. So even though we know that exercise is recommended, we know that there's glycemic challenges involved. So how do we combat that? And it's really balancing how much insulin do you have on board. So the early 2000s, when people started doing studies of what recommendations should we be offering to people of how much to reduce insulin based on the activity that they're doing. So this study was kind of the foundational study, and we really still follow a lot of these guidelines today, that depending on the activity, so 25% is a light activity, you can sing, you can talk, you know, just on a walk with somebody. 50%, you're getting it. I can't sing to you, but I can talk to you. 75%, leave me alone, I'm gonna talk to you in a short sentence only. And the more activity you do, the more we should reduce your insulin by. And this is primarily focusing on your mealtime insulin. So if it's going to be 30 minutes of exercise, kind of just 25, 50, 75% reductions. If you're going for longer durations, you're going to have to reduce a little bit more. And if you're going to be given all you got for at least an hour, you probably don't even need to reduce insulin. And I should say, these are just starting points. Everybody living with type 1 diabetes is very specific to them, and you have to titrate to them. So this is a lot of times we just start, these are the recommendations we go with, and then we change. These recommendations came from this particular study, and what they're showing you is that when you put more insulin in someone's systems, you go lower. So the first figure A there is they exercised for 60 minutes at a light rate. The bottom line is they gave 100% of their insulin dose calculated at the time of activity. The top line, 50%. So if you got less insulin, you had a lower probability of having hypoglycemia. Figure B, same exercise, but they did either a 50% reduction of insulin or a 75% reduction of insulin. And those who only received 25% of what was called for had higher blood sugars than those that had 50%. Same group said, all right, well, we did it for 60 minutes. Let's do it for 30 minutes, and pretty much showed the exact same things. When you reduce somebody's insulin before activity, they're less likely to go low. So again, Mike Rodell and his group come out in 17, and they said, you know what? Yep, research backs all this, but what about timing? Like, when should people start reducing their insulin? It's hard in pediatrics because those of you with kids know that sometimes they eat and they go play. Sometimes they eat and they do nothing. Sometimes they don't want to eat at all. It's a challenge. But Rodell and his group said, all right, if you're going to be participating in activity 90 minutes within times of eating, you need to reduce your mealtime insulin by pretty much the exact same things that were showed in that previous slide from 01. And then he went a little bit further and he said, if you're given all you got, 80% or more, just eat and go for it. So, all right, we've got our recommendations for mealtime, but what about, our basal insulin? So most people in today's world are using pumps. There are still people that taking basal shots, living with type 1. But these next few slides here, we're looking at just at basal reductions because, when you are participating in activity, you can run low during the event, but it can be after the event as well. Again, it depends on the intensity and the duration that you went. I have a cross-country runner who struggles with lows 6 to 8 hours after they finish their long runs. So reducing basal in that individual is of great importance. So this study here said, okay, let's just look if we stop a pump right before they start activity, if we reduce the basals by 50%, or if we reduce the basals by 80%. If they were reducing, they were going to start about an hour and a half before. And what they're showing that if they stop the pump right before activity, individuals have a higher risk of going low because they have more insulin on board. And the more you reduce the basal, the less likely the risk of going low is. They also looked overnight because, again, that fear of nocturnal hypoglycemia is very real. They did find that those who had their pumps stopped right before activity did have more hypoglycemia overnight. But if you looked at statistical significance of all three groups, it wasn't there. The other group still had their fair share of lows as well, just a little bit less. And now in the world in which we live, we have these smart pumps or automated insulin delivery pumps, where if you're wearing a continuous glucose monitor and a smart pump, they communicate with each other. It has revolutionized diabetes care. We're seeing particularly kids have, better time in range, better A1Cs than ever before. But they come with challenges as well, where historically, a lot of times before anyone would go exercise, we say, eat a snack, get your blood sugar up to 150, 180, whatever it may be, and don't give as much insulin for it. Well, with a smart pump, if you go eat a snack to raise your blood sugar, well, that sensor is going to recognize your blood sugar is going up, and it's going to start sending those numbers to the pump, and the pump's going to start giving you insulin. So your insulin on board is going to start to increase. So we're trying to figure out strategies as to how to handle the new technology that we're using, because it's wonderful when you're at rest and doing kind of your normal day-to-day living. More of a challenge though with activity. So this is probably the most recent paper that came out in 23, kind of on the guidelines, and it's kind of saying just try anything and everything. So a lot of these smart pumps have activity modes. And you can turn those on. You can set the duration of how long you want to run them for. And when you go into an activity mode, what it does is it takes the targets and it raises them. So it's not trying to correct you as low as you would be if you're at a normal time of day. Some people will say activity mode doesn't work for me. And then those individuals will say, well, take your pump out of automatic mode and go back to kind of a manual mode where you can adjust those basal rates and you can reduce by 50%, 80%, 75% for however long you would like. That works well for a lot of people still in today's world. Food, with these particular pumps, that 90-minute rule is starting to turn more into an hour to 3 hours. If you're going to be eating, go ahead and start reducing your insulin, again, to have less insulin on board before you start your event. Some people will say automatic mode works great for me. So they just leave it in. So I think all this is to say that when it comes to living with type 1 using these smart pumps, you really have to tailor it to the patient. There's some guidelines to kind of try, but then you have to fit it into that person's lifestyle. So kind of what probably hopefully a lot of y'all want from this talk is just kind of the technology of it. So continuous glucose monitors. I'm sure probably many people in this room have seen these, maybe been using these. But a CGM is just a small device about the size of a quarter now that you place either back of the arm, belly. Heck, some people wear them, forearms, calves, a lot of places you can put them on. And just every few minutes, they're giving you a blood sugar read, or I should say it's reading your interstitial fluid. So there's a lag time between what your blood sugar is and what the reading it's giving you. But these devices have gotten really good over time. Most stay on the body now 10 to 15 days. Many companies make those, but the way they work is all very similar in the sense that there's just a little filament that sits right underneath the skin, and that's sensing your glucose and your interstitial fluid, and then it sends a reading back to either an app on a phone or a receiving device that comes with the product. Here's just a slide of, the different ones that are on the market. You can see the thickness of one is about the size of two pennies. Some have big transmitters on the outside, some do not. The way that you put them all on is a little bit different. They can be calibrated. If you're seeing like big discrepancies between finger pokes and what you're getting on your CGMs, you can calibrate to bring them closer together. It's not recommended to calibrate if you're like after a meal or if you're seeing a big swing in your blood sugars, give it some time there. But they do work very well. And just using a CGM alone has been shown to help improve people's time in range and A1C. And then the way kind of smart pumps work is if you wear a CGM and a pump that has the capabilities to communicate to that CGM, the pump will make changes to insulin. So when you start using a pump, it's just short-acting insulin only. And it's always infusing just a little bit of insulin to cover your basal needs. And then when you eat, you put your blood sugar in the pump and you tell it what your blood sugar is, and it'll give you a bolus of insulin to kind of cover that food. So when the smart pump is working, it's constantly sensing what your blood sugar is, and it's constantly adjusting your basal rates. If your blood sugar is starting to decline, it'll decrease basals. And if you go less than 70, it just suspends itself. So it's not continuing to give you insulin. And then once you come back above 70, it turns itself back on. If you're a kid or anybody who doesn't bolus with a meal, blood sugars will rise. The pump will increase basal rates. And if you're staying too high for too long and it's not fixing it just with basal adjustments, it'll give you a little mini correction of bolus. Depending on the pump, it does it a little bit differently, but on average, it's about a 60% correction of what a full correction would be. I've got a teenager who refuses to put carbs in his pump. Smart kid, he just refuses to do it. His A1C is now staying in about the 8 range because of pump technology. If he wasn't on a smart pump, his A1C would be double digits. But because the pump is making so many corrections on the back end, it helps him out. And these pumps come in different type versions. Like this is particular tube pump where you have the infusion set attached to the individual, and then it connects to the pump, and there's a reservoir there where the insulin is stored. There's tubeless pumps on the market as well, where it's just you don't have the kind of the tube, if you will. It's just a pod that's full of insulin that you stick to your body. A lot of our athletes, though, will still choose to stick with tube pumps because they can just disconnect during times of activity, which they like having something like less bulky on their body. And they just kind of monitor their blood sugars during their event. We tell them check about every 30 minutes or so. And then if they do need to, if their blood sugars are going high and they need a little correction of insulin, they can just reattach, get a little bolus in over a minute or so, and then go back on with life. There are many different smart pumps on the market today, but again, they're all working with CGMs and having that talk for it to happen. Pump devices are getting smaller. I think a lot of pump companies are trying to go the tubeless route because a lot of families do like that. And this world is changing too. Just right now, most pumps still require you to count your carbs and put your carbs in the pump. There's a pump that come on the market over a year ago that you just tell it you're eating a small meal, big meal, moderate sized meal. It does its algorithm calculations to determine how much insulin to give you, which is wild technology. And the technology is just going to continue to get better as we move forward. With our technology, I just put this up there for if y'all want to see it as well. Like there is guidance on how somebody should manage their blood sugars in terms of what they're seeing on their CGM. The CGM gives you arrow sign. So if you have double arrows down, you're dropping 90 milligrams per deciliter in the next 30 minutes. If your blood sugar is 110, well, that's normal blood sugar. You probably should go eat a snack because you're going to go low because you're dropping too fast. But also gives you up signs as well if you need to take insulin. So this was a nice slide that came out a few years ago that just said, depending on what your blood sugar is, what arrow sign it's giving you, some advice as to eat a snack, don't eat a snack, take insulin, go on with life. And then I would just so you are aware of our resources here in Louisville, because I will say I think we live in a very blessed area when it comes to just the resources we can provide to our kids and our families with type 1. That we do have a sports program that has an exercise physiologist and dietitians who can give our kids with type 1 just a little bit extra love and care when it comes to them trying to achieve their goals, whether it's to go on to the next level at college or just be the best version of themselves they can be in high school, where we do kind of deep dives into their physiology, getting their VO2 max and all sorts of fun body metrics, and then really working with them on their food plan, because most people just eat way too many carbs and not enough of the healthy proteins and fats to help themselves fuel appropriately, but also with their diabetes plan as well. And then these are just some of the guidelines that we have created ourselves based on our experience and then looking at the literature as well as to how to reduce insulin, eat, fuel yourself appropriately. And with that, I thank you all so much.